Hello everyone. I'm myself Dr. Rajesh Gubba. I'm the general medicine educator. In this session, I'll be doing a quick recap on the topic of the neoplasia of the thyroid gland. So, first of all, you should know what are the types of the thyroid neoplasia. So, we have four important types that includes the follicular carcinoma, papillary carcinoma, medullary carcinoma, and the anaplastic carcinoma. So these are the four important types of the thyroid carcinomas. Now, among this, what is the most common type of thyroid cancer? Please remember, the most common type of thyroid cancer is papillary carcinoma. Papillary carcinoma is the most common thyroid cancer, which is seen in almost 60 to 70% of all thyroid cancers. They are papillary carcinomas. Now, what is the risk factor for the development of the papillary carcinoma? A very important question. It is the history of radiation exposure, right? That is the important risk factor for the papillary carcinoma. Now, what is the peak age for the development of papillary carcinoma? It is having a bimodal frequency. That means one peak will occur at around second or third decade, and then again later in the life there will be another peak. So that is what is called as the bimodal frequency. Next. And let me tell you, this papillary carcinomas, they are more common in women rather than men. Now, what is the mode of spread of this particular papillary carcinoma? So, papillary carcinoma, it is a slow growing tumor and this spreads via the lymphatics after many years. And how do you treat this particular papillary carcinoma? So, if you see the treatment is surgery. If it is like small tumors which is limited to a single area of the thyroid gland, then you do a surgical resection of the tumor. Whereas if it is a large tumor, then along with surgery, even radiation is also required, right? Along with surgery, the radiation is also required. So that is the treatment for papillary carcinoma. Next. And the TSH suppression therapy with levothyroxine is also used. Then, next important question is, which carcinoma is common in elderly individuals? The carcinoma which is common in elderly individuals is the follicular carcinoma, right? Follicular carcinoma, it constitutes nearly 15 to 20% of all thyroid cancer, but that is the most common type of thyroid cancers in elderly individuals. And it is more common in women rather than men. Then, and let me tell you, compared to your papillary carcinoma, your follicular carcinoma, it is highly malignant. Then, how does it spread? So it is being spread hematogenously. So we have discussed that papillary carcinoma is being spread through lymphatic route, whereas the follicular carcinoma is being spread through the hematogenous route, and it will have a distant metastasis to the lungs and as well as bone. So this is what is the spread of the follicular carcinoma. Next, how do you treat this follicular carcinoma? So treatment requires the near total thyroidectomy with post-operative radioiodine ablation. See, for papillary carcinoma, we have discussed that if it is like a small tumors, you need to do surgical resection of the tumor. And if it is a large tumor, along with surgical resection, right, radiotherapy is also required. Okay, so then if you take the follicular carcinoma, the treatment requires near total thyroidectomy with post-operative radioiodine ablation. So this is the treatment of the follicular carcinoma. Now, coming to your anaplastic carcinoma. Let me tell you, anaplastic carcinoma, it is also the tumor which is primarily seen in elderly patients. And it is more common in women rather than men. But it is the rare form of the thyroid cancer. It is just seen only in 1 to 2% of all the thyroid cancers. And what are the characteristic features of the anaplastic carcinoma? Let me tell you, among all the types of thyroid carcinomas, your anaplastic carcinoma, it is a highly malignant tumor, right? And it undergoes rapid enlargement of the thyroid gland, and it will be a very painful enlargement of the thyroid gland, and 80% of the patients, they die within 1 year of diagnosis, right? Within 1 year of diagnosis, 80% of the patients will die. So these are the characteristic features of the anaplastic carcinoma. And how does it spread? So this cancer, it spreads by direct extension. So if you take the spread, papillary carcinoma, lymphatic spread; follicular carcinoma, hematogenous spread; anaplastic carcinoma, by direct extension. Then what is medullary carcinoma? It is another form of the carcinoma. So medullary carcinoma, it constitutes 5% of all thyroid cancer, and it is the malignancy which is originating from the parafollicular cells or the C cells of the thyroid gland. So, and it is also more malignant compared to that of your follicular carcinoma. Now, what does it produce? Because it is a tumor which is originating from parafollicular cells or C cells. So what does it produce? So this medullary carcinoma of thyroid will produce an important hormone, that is calcitonin. And it is the only thyroid cancer with elevated calcitonin. And what does the calcitonin does? It is the hormone which will decrease the calcium. It will take the calcium from the serum or plasma and it will dump the calcium into the bone. So thereby calcitonin will reduce the serum calcium levels. Okay, so that is what is done by your calcitonin. Now the question is your medullary carcinoma of thyroid, is it a part of a MEN syndrome? Yes, it is a part of MEN syndrome. See, MEN syndromes, if you take, like we have MEN1, MEN2, MEN3, and then MEN4. Multiple endocrine neoplasia type 2, it is of two types, MEN2A and as well as MEN2B. MEN2B is nothing but your MEN3, right? MEN2B is nothing but your MEN3. And your medullary carcinoma of thyroid, right, it is the component of MEN2, right? It is a component of MEN2. So it is a component of both MEN2A and as well as MEN2B. MEN2A, it is also called Sippel syndrome. And what are the malignancies in MEN type 2A? In MEN type 2A, right, you have a mnemonic called TAP. These three are the malignancies in MEN type 2A, which is nothing but your Sippel syndrome. T stands for thyroid, that is medullary carcinoma of thyroid. A stands for adrenal pathology, that is adrenal pheochromocytoma. P stands for parathyroid hyperplasia. So this is what is the malignancies in MEN type 2A. So you can see that the medullary thyroid carcinoma, it's a part of your MEN type 2A. And you take MEN type 2B, which is nothing but MEN3. And another name of your MEN type 3, it is Wagenman-Frobois syndrome. And the malignancies in MEN type 2B is only two, right? That is thyroid, that is medullary carcinoma of thyroid; adrenal, that is adrenal pheochromocytoma. And we have even some neuromas as well. But endocrine tumors, only these two, that is medullary carcinoma of thyroid and as well as the adrenal pheochromocytoma. Now you have to understand that in MEN2, the chromosomal abnormality, it is present on chromosome number 10. That's an important multiple choice question. And the gene which is being mutated in MEN2 is RET proto-oncogene, right? Next. Having said this, what are the other malignancies where the calcitonin is high? Among the thyroid carcinomas, it is only medullary carcinoma of thyroid where the calcitonin is high. But other malignancies like carcinoma of the lung, pancreas, breast, and as well as the colon. So these are the other malignancies where the calcitonin levels will be very high, right? This is a very, very important question. Next. Now, how do you treat these patients with the medullary carcinoma of thyroid? So if you see the treatment, the only effective treatment in this patient is the thyroidectomy, where in case of medullary carcinoma of thyroid. Next. Now, when will you suspect the development of the thyroid carcinoma? So number one, there should be recent growth of the thyroid or mass with no tenderness or hoarseness, right? There should not be any tenderness and there should not be any hoarseness, right? There should be recent growth of the thyroid or the thyroid mass, and history of radiation, right? History of radiation to the head, neck or upper mediastinum in the childhood. So that is also one of the suspicious thing that the individual might have developed the thyroid carcinoma. And when will you suspect the thyroid carcinoma? Some more points. The presence of solitary nodule, right, is another suspicious thing of development of thyroid carcinoma. Next, calcification on the X-ray, such as Samoma bodies, that will suggest the papillary carcinoma, and increased density on the X-ray will suggest the medullary carcinoma. So these are the points to tell that the individual had or might have developed the thyroid carcinoma. And another important is, what is the first test to do in a patient with a thyroid nodule? See, the first test that you will do is the TSH. Okay, the first test you have to do is TSH, and if that is normal, then you have to proceed to the FNAC, right? And evaluation of the solitary non-functioning nodule is done by the FNAC for most of the patients. And the next thing is ultrasonography, and the purpose of doing an ultrasonography is mainly to differentiate whether it is a cyst or whether it is a solitary nodule. That is the purpose of doing the ultrasonography. Next, what is a thyroid adenoma? So if you take thyroid adenoma, it is a non-functioning or hyper-functioning thyroid tumor, and they are slow growing tumors which occurs over many years. And if you take the types of thyroid adenomas, they can be follicular, papillary or Hurdle, but most common is the follicular thyroid adenoma. And how do you manage these thyroid adenomas? Management of the hyperfunctioning adenoma include the ablation with radioactive iodine. So that is how you will treat the thyroid adenomas. So with this is a short note on the topic of the thyroid malignancies. Thank you very much.